Good afternoon, everyone. I am Dr. Paolo Victor Medina. I am community medicine practitioner educator with the UP College of Medicine and the UP Community Health and Development Program, a proud member of PASCOM, and I am very privileged to be able to contribute to this week's APMC-PASCOM workshop series. And the task that was given to me was to be able to present our learners' perspectives on the teaching and learning of primary healthcare in basic medical education. So I entitled it Learning PHC. And I know that everybody is on board with this. We are compelled to reorient our basic medical education curricula towards primary healthcare because of the implementation of the Universal Healthcare Act, particularly outlined and articulated in Chapter 6 of the Human Resources for Health, Section 25.10. And I believe that, and as I often say to my students, we will never lose our way if we never lose sight of our why. And so I think we should re-examine and remember and be very mindful about why is there a need to reorient our basic medical education curricula to primary healthcare. And it always begins with why, because once we answer why, and this is shared amongst us basic medical educators, we are now going to be challenged to work collaboratively together to determine how. And then ultimately, this impacts the what, which in my head is very much aligned with our goals of outcome-based medical education. We want to be able to create or produce the outcomes, which is the Filipino general physician. But to be able to do that, we have to go back to the why. And this in turn sets up the policy context for primary healthcare and basic medical education. In my head, there is that law, the UHC Act, included that very, very telling clause on the status quo of basic medical education in the Philippines. For lack of a better term, the basic medical education curricula that we have, it's skewed towards something else. Therefore, there is an absolute need to reorient. And I believe as a community medicine practitioner that the skewing is towards hospital centricity, specialist-driven conversations, and the biomedicalization and inordinate amount of focus on healthcare delivery, which is not wrong. Don't get me wrong, please. That is not incorrect. That's actually a big part of what we do as physicians. So we need to produce graduates, outcomes, doctors who are very comfortable with providing care in the hospital setting because that is the basic competency. But the status quo is that we are not producing the intended outcomes that are holistic in our basic medical education programs, or maybe the more correct terms, we are just partially producing them. Because I don't know about you, but I will say this with a lot of confidence, and that presently, our graduates are very comfortable being physicians in a clinical hospital setting. But in terms of the dimensions of being a physician as members of society, we are not very comfortable with that. And as a former municipal health officer and still a teacher, practitioner of community medicine, I can assert to this in the day-to-day practice that we ComEd practitioners do. And so again, this compels me to ask the question, why is the Filipino general physician? Why? And then the how and what will follow. And so I was tasked to be able to contribute to the workshop of APMC and PASCOM for all of you in terms of sharing. And this is what PASCOM also values. As educators, we believe that the learner's perspective is very important because they are our outcomes. And we are only relevant because we are able to transfer what we have, share what we have, so that it impacts practice, and it's practice that shapes the health outcomes for the country. And so I have been tasked to be able to just share with you a few of the perspectives of primary healthcare that I have gleaned from three sources. One is a focus group discussion, which is done this month with representatives from the APMC student network. These were four clinical clerks who were invited to give me their perspectives on primary healthcare, and they came from NCR, Luzon, Visayas, and Mindanao medical schools in an attempt to capture the breadth of the learning and experience of our students in terms of primary healthcare. And then I would also like to share with you some insights from the primary healthcare module in the course CE298, which is work for our Masters in Public Health learners of the Dr. Sudabarius program at the DOH, specifically from batches 37 and 38. And I included this because I felt that as very recent medical graduates who are now thrust into practice, and again, this is my bias, as a former municipal health officer, I believe that the DTTB MHO role is very much very good and rich opportunity for primary healthcare practice. So I wanted to be able to present their thoughts to you. And last but definitely not the least, our continuing work in the UB College of Medicine, particularly the Community-Oriented Medical Education Unit, where we did a series of evaluations of how we were doing COME, or Community-Oriented Medical Education. And together with Drs. Leah Palileo Villanueva and Dr. Jean Esperos, we tried to be able to capture the thoughts of our students in terms of how they were being taught in medicine. And so I included this because I think in terms of our reorienting the curriculum, the curricula of our institutions, these can potentially be very useful for all of you. And so I first present the insights from the focus group discussion with the APMC Student Network clinical clerks. And what's interesting in those conversations is that, well, this is encouraging. Primary healthcare concepts are taught in med school, and it's great. I believe that as a doctor with little over a decade of experience, I am very encouraged by this, that when we talk to the medical students now, there seems to be a normalizing of these primary healthcare concepts, and the principles are taught. However, when you get to talk to the students, there's that feeling that the principles are not tackled in depth. And this is because, well, the application is very limited in terms of the learning environments. Their education, and this is coming from them, it's really inordinately hospital-based. And well, if they do go out in the community, it's in community clinics. But they do have an appreciation of the lectures, especially when you talk to them about health for all and primary health care and the concepts that are from the Almata Declaration. There seems to be an intuitive grasp of them that there's something that they're missing out on. And they also shared very specifically that in terms of the role models, meaning the teachers that they encounter in terms of primary healthcare concepts, somehow they look for the ones with the significant experience and know-how who can really walk them through the variations, the dimensions, the challenges of doing primary healthcare. And this was even before the pandemic. And because the insights and the learnings that they have in terms of primary healthcare are in just one subject or rotation, which is for most of them family and community medicine, when they shift out, they bring with them this basic understanding, but if it's not followed through very well, PHC is easily misunderstood to be about just healthcare, which is equated to primary care and health systems. And that's where the extent of the holistic aspect lies. It's really about service delivery and creating structures for these things, instead of what is taught to them, just lectured or discussed, maybe in passing, maybe not, that health is a social phenomenon. And when you talk to the students, especially in recent years, there is hope because they are seeing that that void or that gap in terms of learning about primary healthcare is being filled mostly with extracurricular and student-led organized efforts. For example, immersions, public fora, and discussions. And this is not good because these things are not intentional from an educator's perspective. It's good that there is something that fills in the gap, but we are going to be reorienting curricula. And maybe we can look towards these examples in terms of teaching and learning primary healthcare. And when we go to the DDTB MPH learner primary healthcare perspectives, in that course, the module that I particularly handle, as an introduction and a leveling off, I ask them to record in their own words a definition of primary healthcare and to recall how they've done primary healthcare if they've already done primary healthcare in their practices. And what was telling to me is that, well, while primary healthcare is still very much conflated with primary care, and it's understandable given that they are the first contact of patients with the formal health systems that are in place, and of course they're running those systems, this is now tempered with insight into health systems management at the community or population setting. And therefore, the understanding and appreciation of health as multifactorial is better. And because in that setting of practice, and again, I share that, I know that this is not education per se, but we need to be able to make the connection. Practice is where the teaching and learning happens. And so in the DDTB's practice, where they are as municipal health officers and rural health physicians, there are more opportunities for intersectoral collaboration and people's participation, which is basically through community engagement. But somehow these are unintentional at best, except for those institutions with strong backgrounds, and they all share that. I am from this particular institution. I am blessed to have had these experiences before, so that when I see them now in my practice, I don't have a baseline that's zero. I actually am drawing from previous opportunities, similar to what we do when we rotate or maybe practice in a hospital. I look to my former medicine or pediatrics or gynecology rotations and match my current experience with what I learned. So the DDTBs, while they are sharing that they're able to now do primary healthcare, it is unintentional. And they share that they struggle with it despite being there already in those settings. And the relative unfamiliarity to the primary healthcare principles, the in-depth principles, compels most DDTBs to inordinately focus on just setting up effective primary care health service delivery systems. But then in that same experience of doing this, there's always that insight that this is limited because health is multifactorial and where best to appreciate this, but in the community setting. And so by being there, they are forced to do better with the social determination of the social determinants of health. And last source of insights into our learners' perspectives and experiences in primary healthcare would be the UPCM COM evaluations that we did back in 2018. And the discussion in the COME unit is that COME is the operationalization of the primary healthcare approach, which is lodged in the UPCM vision mission. And this is regardless of chosen path as a physician. And this was an insight feedback from current students and recently graduated alumni. And their realization is that COME is being equipped with a contextualized perspective in dealing with patients who are members, part of their communities. And the health conditions that these patients present with, experience, are a result of the societal forces they experience. And therefore, whatever discipline you choose, health interventions need to be anchored on an understanding of what these societal forces are. And so our graduates and our students, when we talk to them, they express this need, which stems from an appreciation that their current setup is quite limited. And basic medical education must go beyond just medical management. The person is a whole, and that person comes with all of the societal baggage that defines and determines who that person is. And therefore, if that person is the subject of the teaching and learning, then the teaching and learning should touch on all aspects of what makes that person a person. Health is not just physical or mental well-being, it's also societal, social. And in this aspect, the students and alumni say that the faculty role cannot be overemphasized. And I'm sharing this because I believe that those three experiences and perspectives are tied up with that very nice progression of how students appreciate what they're being taught, and then suddenly they're thrust into the practice, and then they suddenly appreciate more that they were taught, and they realize that, and they say, and you observe, and you kind of make the connection that they should have been taught more. And then here comes our COME evaluation. And again, I'm very biased because this is an effort that we did. But I believe that if we share this with you, by sharing this with you, there's that opportunity to go just beyond community medicine, of which I am a practitioner. And again, as I said, COME is not community medicine. It is the operationalization of the primary healthcare approach, which is the UPCM's vision mission. And hopefully that is a vision mission that's shared among all medical schools in whatever form or version that is. And so what are the misperceptions or misexperiences and opportunities in terms of the learning of PHC in the status quo? Well, it's very clear. Primary healthcare is not primary care, with the latter being an integral part of it, but it is not the be-all and end-all. And this is underscored, especially with the DDTB experiences in primary healthcare practice settings. And it is encouraging that most, if not all, Philippine medical schools do teach primary healthcare in some form. But the teaching or learning experiences have to change to enable in-depth appreciation of primary healthcare principles. The students were sharing that for some of them, they start community immersions earlier. And so what does that tell us? We need to re-examine the inordinate amount of hospital-centric teaching and learning that defines the present basic medical education. Something has to give. And therefore, if we change curricula, the challenge is to change it, to disrupt what's already there, because we need to give more time for our students and our learners to be in society or the community. And these resulting experiences have to be processed well. And therefore, the reorientation of basic medical education towards primary healthcare, I think, beyond content and methodologies, it's about values. And our students are showing that somehow they are seeing the dissonance between what they're experiencing in terms of the knowledge and skills and the attitudes that we want them to express have to come from that enabling environment. And this is where it becomes very difficult. It's about reorientation towards values. And so PASCOM and primary healthcare, it's nice that you are here because for PASCOM, community medicine is the discipline that's primary healthcare practice. And our practice is that we believe that PHC is an approach to achieve health for all based on the following principles. And you will have sessions on this in the succeeding days, just laying down what is primary healthcare. We need to be able to define it, to understand it and appreciate it, to design effectively how we can integrate this towards our basic medical education curricula. And these principles will be discussed more in succeeding sessions. But I'd also just like to take this opportunity to say that PASCOM, while we are the community medicine discipline, we are saying that because we are the ones who are specializing in the primary healthcare approach, We also have started determining, defining, discussing the primary healthcare approach in terms of what a PHC practitioner should be able to do, the why of GP in the Philippines. And in our 6 pillars, which we shared in 2017, we hope that we can actually spark conversations, not just with fellow community medicine practitioners, but this is exactly what we're doing now. We thank the APMC for giving us a chance to be able to facilitate this process. And if these pillars, which we will run away with because this is our discipline, can also be valued by the other specialties in medicine. And then by doing so, maybe, or is it the other way around? I'm not really sure. We have the content curriculum experts here, but that these values, how can they now change the practice of medicine in the Philippines? Because ultimately, what we are doing is investing in the future by reorienting our outcomes, by reminding the Filipino physician of their why. And once again, we will never lose our way if we never lose sight of our why. Thank you very much, and I hope this helps you in the succeeding sessions. Maraming salamat po. God bless.